Okay, good afternoon and welcome to this public webinar on treating addiction across the care continuum during COVID-19, challenges and promising practices, which has been jointly organized by the National Academy of Medicine and the American Society of Addiction Medicine. My name is Elizabeth Finkelman and I direct the National Academy of Medicine's Action Collaborative on countering the US opioid epidemic, which I'll describe further in a minute. The Action Collaborative has benefited greatly from the participation and leadership of the American Society of Addiction Medicine, represented by Dr. Kelly Clark, and we are so pleased to be collaborating on this webinar together. Today's free 90-minute webinar will provide insights on issues of access to addiction care and targeted guidance on how to effectively keep patients connected to treatment during the COVID-19 pandemic. This webinar is the second in a series called Supporting People with Addiction During COVID-19, hosted by the National Academy of Medicine and the American Society for Addiction Medicine. Today's webinar has been approved for 1.5 hours of AMA PRA Category 1 credits and for 1.5 continuing education credits from NAADAC, the Association for Addiction Professionals. Please note that in order to claim credit and receive the certificate of completion, participants will need to complete the mandatory evaluation at the completion of the webinar. This webinar is being recorded and the video along with the presenter slides will be posted on the NAM and ASAM websites after the event concludes. Next slide, please. Today's webinar will last 90 minutes and will follow the agenda you see on your screens. We will begin with 10 minutes of introductory remarks provided by myself and Dr. Kelly Clark, who will be moderating today's discussion. We will then hear from our panel of speakers who will each speak for 15 minutes. We will then move into moderated discussion with the panel before opening up to questions from the webinar audience. And the webinar will conclude by 4 p.m. Eastern Time. Moving to the next slide, questions and comments from the webinar audience can be submitted at any point during the webinar, and we'll do our best to get to as many of them as we can before the webinar concludes. So please use the comment box on your screen to submit a question. And as a reminder, the webinar is being recorded, so please understand that any questions you submit may be read aloud and included in our recording. Moving to the next slide, we hope that you will join the conversation on social media and tweet over the course of the webinar by using hashtags COVID-19 SUD treatment and opioid collective. Moving to the next slide, I'm now just going to spend a couple minutes providing an overview of the NAM's Action Collaborative on countering the US opioid epidemic. Moving to the next slide, recognizing the need for a cohesive and collaborative response to the nation's opioid epidemic, the National Academy of Medicine established the Action Collaborative in 2018 as a public-private partnership to foster greater coordination and collective action across the health system and beyond in addressing the opioid crisis. The Action Collaborative uses a systems approach to convene and catalyze public, private, and nonprofit stakeholders to develop, curate, and disseminate multi-sector solutions designed to reduce opioid misuse and improve outcomes for individuals, families, and communities affected by the opioid crisis. The Action Collaborative has 3 foundational goals that guide its work. The first is to identify and raise the visibility of complex challenges, outstanding research gaps, and needs of the opioid crisis that require collective multi-sectoral responses. The second is to elevate and accelerate evidence-based multi-sectoral and interprofessional solutions to improve outcomes for those affected by the opioid crisis. And lastly, the Action Collaborative aims to catalyze action on shared priorities and solutions to help overcome the crisis and improve outcomes for all. The Action Collaborative's work is organized around 4 core priority areas, which represent among the highest priority elements of the nation's response to the opioid crisis. These include strengthening health professional education and training around substance use disorders and pain management, improving pain management guidelines and evidence standards, accelerating, sustaining, and scaling prevention, treatment, and recovery services, and elevating pressing research data and metrics needs. Around these areas, we're producing several policy and technical white papers, as well as webinars, public meetings, and a variety of dissemination activities. Moving to the next slide. Of course, with the emergence of the global COVID-19 pandemic earlier this year, the Action Collaborative is pivoting to focus on ways in which we can support substance use disorder and pain communities during this challenging time. As such, we're undertaking a series of activities to be responsive in the near and longer term. We have created a resource page on the Action Collaborative's website to collate and share emerging COVID-19 resources across our Action Collaborative's membership, including the excellent resources put out by ASAM. We're conducting virtual town halls with our members to share updates on ongoing efforts to address the impacts of COVID-19 on the opioid and substance use disorder populations. And in the coming weeks, our steering committee of cross-sectoral leaders will also be releasing a statement highlighting critical priorities and actions that need to be taken in the near term to protect the health and well-being of individuals with substance use disorders, as well as pain in the context of the COVID-19 pandemic. We will also be highlighting pressing and immediate research priorities, and of course, producing publications and conducting webinars such as these on high priority topics. I've only really scratched the surface of the Action Collaborative's activities and efforts, so I encourage the viewers to visit our website to learn more and sign up for updates. So now, if we move to the next slide, I'm very pleased to introduce this terrific and talented group of experts whom you'll have the pleasure of hearing from today. Today's discussion will be moderated by Dr. Kelly Clark, who is the immediate past president of the American Society of Addiction Medicine. And joining Dr. Clark are Dr. Margaret Jarvis, who is Chief of Addiction Medicine for Geisinger Health, Dr. Melissa Weimer, who is an assistant professor and medical director of the Yale Addiction Medicine Consult Service, and Dr. Vincent Nelson, who is Vice President of Medical Affairs and Interim Chief Medical Officer at the Blue Cross Blue Shield Association. Viewers can download and read their impressive biographies on the webinar event page to learn more. And with that, let me turn over the presentation to Dr. Clark. Thank you.
Thank you very much, and thank you to everyone for joining us on today's webinar. The webinar again is on supporting addiction treatment during COVID-19, and specifically today about treating addiction across the care continuum during COVID-19. Well, we know that everyone is focused on COVID-19 right now, and that there are a number of challenges that have occurred in the treatment of opioid use disorder and all of addictive disease because of COVID. And so next slide, please, just to remind folks that our objectives today are that by the end of this time, you'll be able to discuss unique challenges to substance use treatment providers and patients during this active pandemic, recognize patient-centered strategies for maintaining substance use treatments and services in a variety of settings, including opioid treatment programs or methadone programs, OTPs, office-based opioid treatments or OBOT, residential treatment programs, acute care settings, and so on. That you'll be able to describe effective protocol to mitigate infectious risk in both outpatient and inpatient settings, and to identify strategies to ensure effective protocols for coordination between the different care settings during this active pandemic. Next slide, please. So just very briefly, ASAM is the largest group of addiction physicians in the country, over 6,000 physicians, having had our annual meeting for over 50 years. We have an interesting structure to the organization with state-based chapters and regions. So utilizing the expertise of people on the ground to see what's happening in each area is extremely important, to take guidance from federal stakeholder groups, national stakeholder groups, and distill that down, and then activate people that are in the field, seeing what problems they're facing in the states, because the federal government can say, well, you may do this, but the states may have more restrictive regulations in place that will need to be addressed to really make these changes. So ASAM built a sort of an emergency COVID task force, which I vice chair, and we've been coordinating between sort of a top-down and a bottom-up approach. Next slide. There is a website that you can go to here. You can just Google ASAM and COVID, and it will bring you to this. Next slide, please. And just as a very quick overview, and as much as I hate to read slides, I understand that many people may be listening without the ability to be watching currently. So I want to say, for you who are looking for guidance, there's published guidance from ASAM on how to address addictive disease during COVID, specific to infection mitigation in outpatient settings, in residential settings, telehealth guidance, how to adjust drug testing protocols, access to buprenorphine in office-based settings, access to care in opioid treatment programs, support group guidance, guidance on medication dosage and formulation considerations under COVID, treating pregnant women with OUD under COVID, criminal justice considerations in treating addiction during COVID, guidance for general hospitals has most recently come up with the help of Dr. Weimer here. Next slide, please. And soon there'll be additional guidance on access to alcohol use disorder and withdrawal treatment, clinician well-being, and homeless populations. So next slide, please. Really important to understand that this guidance has gone up within the past 2 months, and this is guidance. So this is a very streamlined, very rapid process developed guidance by a few experts here. Dr. Jarvis, particularly extremely helpful in a number of these pieces of guidance as part of a very small review group, very quickly releasing this to address this pressing crisis. And now we're in a process of updating these documents, as opposed to guidelines. Clinical guidelines is a very slow process, which is developed with very rigorous methodology that Dr. Jarvis can speak to at length, with a very rigorous approach. So what we're dealing with here is guidance to address our crisis. Next slide. And there are 3 underlying themes that we notice that from sort of bottom up and top down. And the first theme is really that clinicians and treatment programs and systems of care really need to pivot during times of disaster, such as this active COVID situation, from traditional best practices, which rely on our usual resource availability. And we need to pivot from that into providing the best care possible under the circumstances that are possible, using the resources that are available in the community. And those things have changed radically under COVID, but that is one underlying theme. Next slide, please. The second theme is that there's been very rapid and very deep federal guidance with regulatory changes. CMS has been very aggressive in making payment changes, particularly around virtual visits and et cetera. But these changes have to be implemented within state and local regulatory and payment structures. And so in order to allow that to happen, we really need to make sure that the people on the ground, the people in the states, are very actively engaged in making the changes that are necessary to support these practice changes so people can access care. And finally, next slide, please. The third theme really is that there's an urgent and emergent need for clinicians and entire treatment programs and entire systems of care to break from these silos that have been in place and to collaborate to build new systems of care that have not even existed yet. Next slide. It's very important that we consider the different phases of this pandemic. So in most parts of the country, we are in an early phase where there's a very low population prevalence. And under those conditions, programs can isolate people who may be considered infectious or are unknown to be infectious or not, staff as well as patients. But in the middle phase, when that patient prevalence goes up, the population prevalence goes up, and now 30, 40, 50% of the population is potentially infectious. And now isolating individuals really isn't possible. And so what folks need to think about are perhaps parallel kinds of care for people who are at high risk to be infectious versus those who are at lower risk to be infectious. And that's baked into some of the guidance. And then finally, we have this sort of post-acute pandemic world where we'll have updated best practices that are based on the lessons that are learned. So the overlying things that we've looked at that have really come bubbling up as we've been addressing this issue of during an opioid crisis, now we have this incredible disastrous pandemic. Next slide. So with that, I'd like to say that you can email and please give us your information, questions, and et cetera at covid@asam.org. These slides, of course, are going to be available to everyone later, as well as the recording of this. And you can get this information really by just Googling ASAM and COVID. And so with that, next slide, I would like to turn this over to Dr. Margaret Jarvis to discuss these challenges within primarily addiction treatment programs in outpatient and residential settings.
And thank you so much, Dr. Clark. We are very happy to be able to put this together. Let's go to the first slide. Thank you so much. So as we have considered how to manage treatment of patients with substance use disorders in a time when we don't have our normal resources, the concerns have been, as Dr. Clark says, really figuring out what is the next right thing to do when we don't really know what the next right thing to do is. We do know that the crisis itself is causing stress that is going to increase the use of substances In many people, many who already have substance use disorders and many who may develop substance use disorders during this period of time. We have seen people who have been isolating in their homes, consuming large amounts, especially of alcohol. And the withdrawal syndromes that may come from that are going to be more severe than those patients may have experienced previously. We are also aware that there are changes to the drug supply, quote, on the street, end quote, and that plays a part in how people try to access care, what happens when they do find drugs to use, and this is a concern for overdose. Next slide, please. So there are certainly aspects of the life of somebody who may have a substance use disorder that both through physiology and through sociology would contribute to the potential risk for COVID-19. These include the pulmonary and cardiac injuries that can be sustained simply by dint of having a substance use disorder. Then there is the risk-taking in the search for drugs and alcohol, as well as the lack of housing and inability to do appropriate social distancing that occur as people are under the influence of an addictive disease itself. This is a situation in which people cannot make decisions that are in their own best interest. And they will, under every circumstance, risk their own health in order to obtain and use drugs of abuse. Next slide, please. So, as we consider outpatient care in particular, there are a number of things that many systems, many outpatient treatment providers have adopted in response to the virus. These include improved infection mitigation protocols, which include things like removing some of the chairs from the waiting room so that people aren't sitting close together, modifying the protocols and the staff in order to make sure that we are screening patients appropriately as they approach the office, as they come into the office, and if they are identified as having symptoms that might be suggestive of viral infection, rapidly moving them into an isolated office, masking them, masking all of the people who are around them. There has been a great deal of emphasis and effort put into looking at who really needs to be seen in person versus virtually. And every system, every group is defining that a bit differently. And this is a place where we will have learned so much about the treatment of substance use disorders when all of this calms down and we can reflect on what we have learned. Next slide, please. So in terms of looking at the mitigation guidance, as I said, there's a lot about screening for patients, being careful about how close people get to one another, considering who needs to be seen urgently versus not urgently, making sure people are triaged appropriately based on the resources that are still available in any given community. Next slide, please. And here are some of the resources that ASAM has put together that may be helpful. Next slide, please. So particularly in light of the opioid epidemic, there are some pieces that are critically important and are a change. The most important of these is that we need to maintain access to treatment. The medications that are prescribed for opioid use disorder are of utmost importance for the life and well-being of the patients who receive them. We need to think about harm reduction here. None of us are able to use the best practices that we were able to use 6 months ago. We're all learning new ways of doing it, and harm reduction really is the true north for this period of time. This gets applied as we think about how many doses of a medication people are permitted to have, how medications are selected, and who needs to be seen in person visits versus telemedicine visits. Next slide, please. There are some reimbursement issues, though I must say, at least in my experience in the state of Pennsylvania, I have been very pleased that the state authorities and the insurers that we deal with have responded very quickly to enable virtual visits to take place and to ensure that payment will be forthcoming for those visits. There are considerations for documentation. There are specific phrases and ways of identifying patients that need to be included in order to fulfill the requirements for the reimbursement. There can be staffing challenges, and there's staffing challenges in many different directions, both the people who are remaining on site to see patients and those who might be working from home or for whom there is no good work at this point in time. So there have been human resources challenges throughout this. There are issues around medication supply, making sure that there are pharmacies open and available who carry the medications needed, and that is more challenging in some communities than others. Next slide, please. There are also considerations around formulation, and probably most importantly in many outpatient settings is whether or not to consider the use of the injectable medications that would require that patients be seen at least monthly in order to receive their injections. There have been many changes in terms of how liberal providers are in giving doses of both buprenorphine and methadone, and these have been appropriately relaxed. There has been much guidance and discussion of the need to increase the amount of Narcan in the communities simply so that it is available when it might be needed. It may not be needed by the individual for whom it is prescribed, but the fact that that individual has it may save a life. Next slide, please. The change to telehealth, which has been truly a tsunami, at least in the life of the folks that I work with, has been remarkable. And we've been grateful for the regulatory authorities and the insurers working with us to make sure that this is possible. Nonetheless, it has not been completely smooth. There have been technical challenges in many ways. We are all learning how to maintain appropriate boundaries while doing everything on a screen. And it has limited the ability to do drug testing, which has been a staple of the treatment of patients with substance use disorders. And again, we will have learned a lot as we can reflect in the coming months about what it really means to be able to get drug screening on a particular time basis. Next slide, please. In residential facilities, the admission of each new person, it carries with it a great deal of risk. And balancing the risk of the admission of that new patient and the potential for a perhaps catastrophic exposure of both staff and the current patients in the residential facility versus the need to treat people with substance use disorders. It has been a balancing act for every residential facility in the country. Next slide, please. There is a need to carefully consider how to maintain appropriate social distancing, how that is going to play off in terms of how many staff are needed on site at any one time, how that is going to impact a daily census and the financial considerations that that brings. There have been any number of changes, not just in visitor policies, but in the visitation that has typically been a large part of residential treatment, where outside participants might bring 12-step meetings into a facility, and that has needed to, that has created a situation where treatment facilities have truly upended their usual way of doing things. Next slide, please. There are considerations for transitions in care, in as much as the community resources that might have existed 6 months ago may not exist any longer as they have closed down because of the virus. So that new considerations about level of care and care options, as well as where somebody might safely be living, become discharge decisions and considerations. Next slide, please. Particularly as we think about homeless populations and whether or not there is an ability for someone who is living on the street to actively and effectively quarantine themselves, this becomes another piece of, can that person be safely discharged? And how do you work with the resources in that environment to make sure that they will be well? Next slide, please. And with that, I will turn it over to Dr. Weimer.
Thank you, Dr. Clark and Dr. Jarvis. It's an honor to speak with you this afternoon. I'm going to talk about some of the challenges in providing addiction treatment in the hospital setting during COVID. Much of my work is based in the hospital, seeing patients who are hospitalized with substance use disorder at Yale New Haven Hospital. Next slide. So ASAM has created some great new guidance on this topic because the hospital is an important setting that we'll talk about to engage patients. So some of the key points that are in the new guidance that was just generated, that you can find the link listed there at the bottom of the slide. We're going to talk about, as Dr. Jarvis mentioned, how important it is to maintain access to care, including medications, while patients are hospitalized. We'll talk about some of the reflections and care that needs to be taken in regard to the COVID-19 risks that could be associated with untreated substance use disorders. Some clinical considerations for hospitalized patients who have substance use during the pandemic that we have seen as reflections. In particular, there's some guidance around the use of long-term intravenous medications, such as long-term antibiotic usage, which may be necessary in patients who have substance use disorder and complications of their substance use disorder from IV or injection drug use. The guidance will also include engagement in addiction care in the hospital, how to safely discharge patients who have COVID-19 and substance use, and then importantly, some guidance around harm reduction, particularly for those patients who are the most vulnerable and may not be able to access traditional forms of treatment or may not want to engage in those traditional forms of treatment. Next slide. So as I said, the majority of the work that I do as an internist and addiction medicine specialist is in the hospital. And the reason that we engage patients in the hospital is that the acute care setting, including the emergency department and our hospitals, are increasingly seeing patients who have substance use disorders and complications of their substance use. And from my experience, I can say that COVID-19, if anything, has only highlighted that our patients who have substance use disorder and addiction are particularly vulnerable to both the virus as well as complications and poor health outcomes, unfortunately. Because of that, it is important that we're able to address those needs even in the acute care setting or hospitalization. And in my experience, and many of my colleagues' experience, hospitalization can be a reachable and significant moment when we can engage patients in many different ways, including screening, engagement and potential motivation for change, and then initiation of treatment. And in so doing, we have a very unique opportunity to potentially break the cycle of addiction for patients who otherwise may have found it challenging in the outpatient setting to do so. And our focus when we're discussing initiation of treatment or engagement in treatment really is to see what evidence-based, medication-focused treatments can we provide. This could include treatment for opioid use disorder, alcohol use disorder, tobacco use disorder, all of which have very important and effective and safe treatments. And in so doing, we can improve patients' chances for recovery. And we've also seen that these treatments, as well as these medications, can reduce hospital and emergency department visits in the future. So we actually see that patients who are engaging in our hospital systems have social vulnerabilities, have other health vulnerabilities. When we're able to initiate these treatments, we can actually improve their health outcomes and their healthcare utilization overall. Next slide. So as I said, I've been treating patients in the hospital throughout the COVID-19 pandemic and have noticed some key themes that I'm going to share with you. And based on these key themes that we've seen, we've had to pivot, as Dr. Clark said, to be able to effectively care for our patients and the unique challenges that they've experienced. And so what I've seen is that the patients coming in who are seeking treatment for their medical conditions are describing a lot of increased stress, like many of us, increased rates of depression, increased rates of social isolation, and these are all leading to, unfortunately, for many of our patients with substance use, increased drug and alcohol use. We've also noted that many of our patients have had reduction of access to the social supports that they typically might engage upon and their medical providers. So they're not able to have the same access that they relied upon for their treatment or recovery in the past, or when they were interested in seeking treatment, they haven't been able to access it as immediately. We've also seen some of our most vulnerable patients having increased exposure to COVID-19 due to ongoing homelessness, crowded housing situations for those patients with unstable housing, increased exposure to COVID-19 due to interaction with drug contacts, not being able to take the precautions that they need to take in order to avoid exposure to the virus, and then the other social vulnerabilities that they have, leading to increased risk of virus exposure. Next slide. As Dr. Jarvis was mentioning, we do have concern that the drug supply within globally, in fact, has become less safe. It was not safe prior to the pandemic, but as the pandemic has progressed, we have seen many of our patients having even less safe exposure to drugs unpredictably. So we've seen patients having increased rates of overdose from unintentionally being exposed to fentanyl or fentanyl analogs. We've seen patients presenting to the hospital with other drug contaminations that are quite concerning. Some of our patients have described that they haven't been able to access alcohol or other drugs with the same availability that they had in the past, and this has led to worsening withdrawal. A general lack of sterile supplies, as some of our needle exchanges or other safe syringe programs have not been accessible during the pandemic. And as Dr. Jarvis was saying, rates of untreated alcohol and opioid withdrawal have been notably higher, where some of our patients are avoiding coming to the hospital for a longer period of time and unfortunately having worsening withdrawal syndromes because of avoidance of hospital care. Next slide. Other interesting things, so, as an internist, I both treat the medical illness as well as the addictive illness, and have treated patients without substance use who have also had COVID-19. And it's interesting to me that our patients with substance use may actually come into the hospital with symptoms mimicking COVID-19, which could be misinterpreted as withdrawal or COVID-19. So it's important that we are thinking about this as a particular risk and screening patients for both when they're coming into the hospital. Because of the less predictable drug supply, we have and less access to sterile injection equipment. We have unfortunately seen some high rates of infectious complications of injection drug use, which is obviously very concerning. We've noted that many of the local regional detox centers have had less accessibility. This has driven patients to the hospital at a time when hospital resources are being stretched. And then finally at discharge, we've seen that unfortunately there's been limited access for ongoing safe shelters. There's notably been less access to skilled nursing facilities for our patients who need that level of care due to certain restrictions around the provision of medication treatments, particularly for patients with opioid use disorder, which was pre-existing to the pandemic, and now again we're seeing highlighting increasingly the urgency of our need to address that issue. And then, a lack of being able to seamlessly transition our patients from the hospital to substance treatment centers, as those treatment centers are also being stretched and may be hesitant to admit a patient directly from the hospital who may have had exposure to COVID-19. Next slide. So some strategies that we have been employing and we recommend that other systems are employing are to make sure that we are screening our patients for substance use and offering treatments when available. We need to make sure that when patients are admitted to the hospital, we're treating the substance use disorder withdrawal, and that in so doing, we are facilitating treatment of their medical condition so that they are not faced with the hard choice of potentially electing to leave the hospital without receiving medical treatment. In my experience, no patient wants to leave the hospital without getting needed medical treatment. When we are able to treat withdrawal or substance use disorder, we've noted that there's less patient-clinician conflict, that treatments are able to be given more readily. Though it's certainly important as we're treating in the hospital that we're partnering with our community partners, our local treatment centers, primary care clinics, so that care can be continued after the hospitalization. We are needing to partner with shelters and other safe locations, particularly for our socially vulnerable patients with unstable housing or homelessness. Working with our local harm reduction programs so that patients who are continuing to use injection drugs have access to sterile equipment and reduce the risk of other communicable diseases such as HIV and hepatitis C. And then always, particularly for our patients with opioid use disorder, making sure that they have access to naloxone at discharge to reduce their risk of overdose. Next slide. So in one, just sharing what our health system has done in response to COVID-19, we've worked with our program in addiction medicine to create guidance both for our community and our hospital around best practices for patients who are treated in the outpatient and inpatient setting. We have transitioned many of our consultations to virtual consults, and in so doing, we've actually seen that in some ways we've been able to provide more care to a larger group of patients, particularly when we're seeing those patients admitted to the hospital with a lot of frequency. We've continued to facilitate medication initiation and treatment while patients are hospitalized. We are continuing to work with our community partners to ensure ongoing access Monday through Friday for treatments such as methadone or buprenorphine. We are working with local community harm reduction agencies to ensure ongoing access to care. And then with community partners and other groups, we are trying to work to ensure that many of the safety net programs such as shelters are able to continue to accept our patients and able to provide things like masks, hand hygiene, and other resources. So a lot of different programs that we've tried to bring together to ensure the ongoing safety and treatment of our patients. So with that, I'm going to, next slide, hand it over to Dr. Nelson.
Yeah, thank you. I'm going to assume that you can hear me. Thank you, Dr. Weimer. And thank you to Dr. Clark and everyone who's invited me here today. It's a pleasure. Glad to be talking to you about such a important topic. I'm representing the Blue Cross Blue Shield Association. The association is a trade organization that represents the 36 Blue Cross and Blue Shield plans across America. Collectively, those plans cover 1 in 3 Americans, over 100 million Americans. So because of our footprint, we definitely consider ourselves to be very significant in the health of America. And we launched a Health of America project a few years ago where we tapped into our data of our members to gain insights into their quality of care and their health, and use that data in a big data strategy that will allow us to have actionable insights moving forward. I brought a few data points from those from this project and our data. And I'm going to focus on the data that is pertinent to how we are pivoting in the age of COVID to make sure that our members are receiving the care that they need in general, and more specifically, if they have substance use disorder. Next slide. And I'm going to go a few slides. Next slide, next slide, and next slide. So I'm going to start here. So what we have been seeing trending in a positive direction is the decline in our members who are diagnosed with substance use disorder. And we have OUD here. The data was combined with SUD as well. And so it's a trending downward direction, which is good. It is not demonstrative yet, but we are glad that it's trending in the right direction, and we are paying close to this. With our 2019 data, we will then have that next data point to be sure of the consistency. Next slide. So this is a heat map of where in America the opioid use rates are highest, and they have, and this is trending to, or this is data that's inclusive of 2018. As you can see, it's parts of the Northeast and the South that have the highest rates, which was pretty consistent in the data we've seen over several years. And so we have been tracking that just to see where our members are in need of treatment more acutely than in other parts of the country. One of the projects that we initiated that became program is our substance use treatment resource centers. We have a Blue Distinction Center program, a national program that's a designation that is given to providers that demonstrate expertise in delivering quality care. There's a lot of specialty care, Blue Distinction Centers within the country, and we decided to also designate substance use treatment centers around the country as Blue Distinction. Now, you are able to obtain that designation by meeting certain metrics based on quality. We follow the ASAM guidelines and guidance based on the quality of delivery for substance use treatment. We also have a metric for cost transparency. We have another metric for scope of delivery. So we also want both technical scope, meaning behavioral cognitive versus medical assisted treatment, and also facility. So residential, intensive, outpatient, and partial hospitalization. So these are some broad domains that we can drill down on in the Q&A, but essentially we are looking for quality care within substance use treatment centers, and you have to meet these metrics in order to get our designation. Next slide. So this shows you how, like again, some positive data on substance use disorder patients that are receiving treatment. Since 2016, that percentage has gone up. And what is more encouraging is that the medically assisted treatment segment of those receiving treatment has gone up substantially as well. And so multimodal therapy, both medically assisted and behavioral cognitive, as well as medically assisted treatment, have both been on the increase. As you can see by the gray shaded area, we still have a ways to go, but we are again trending in the right direction. Another resource that we launched actually in December of 2019, and now it seems very fortunate to have done so, is we also have stood up a substance resource center phone line. The aspirational goal for that phone line is to not just be for our commercial or our members in general, but to the population at large. But how we have rolled it out is we rolled it out in 3 states as a pilot in West Virginia, Ohio, and in Arizona. And this resource line is staffed by clinicians, is staffed by navigators within their local communities, and they use a combination of their knowledge, their resources, and data to determine what best tools are needed for the member who calls or the member's concerned relatives or significant other who calls. We have, needless to say, been overwhelmed by the engagement that we've gotten from our membership, and we are quickly forming a proof of principle and a proof of concept that we will subsequently roll out into our other markets, and then, as I stated, hopefully roll it out as a agnostic to commercial benefit service. Next slide. And so, as you can see here, where medically assisted therapy is highest is does not quite neatly overlap with where the highest need is. Some of that is because of state regulations, as we all know, with controlled substances. That is also kind of in general when you think about treatment. But we are hopeful that with the growth in medically assisted treatment for substance use disorder, that it will become more ubiquitous and pervasive, and we are here to support that. Essentially, we pride ourselves on reducing the friction in patients that need care broadly and specific to substance use disorder. We have taken active steps during this pandemic to make sure that our members receive the highest care possible, as well as the best care and the most convenient care. We have relaxed, in many cases, prior authorization and eliminated it in some cases. We have also, for prescription refills, we have relaxed the rules around prescription refills and early refills. Mind you that we have to adhere to whatever the state laws are around controlled substances when we relax those rules, but we are supportive of the local markets in what they need to get done in terms of getting our patients their medicines and their therapies. And lastly, we have facilitated the no cost sharing in many markets to any medically necessary CDC guidance recommendations around diagnosis and treatment of COVID-19. And we've expanded that in some markets to medical care that is not directly related as well. And this was seen as not just necessaries, but things that we should be doing in this really time of severe need in the country for all of us to step forward and give a hand to everyone out there. That might be my last slide. Could we go to the next slide just to check? Okay, great. And lastly, I'd just like to say I have one plan example, the state of Arizona. Some of our plans are in markets. We have some states that have multiple plans. We have some plans that cover multiple states, and then we have some statewide plans. In Arizona, we have one plan. It covers all the members, and as many of you know, that state was hit very hard by the opioid crisis, specifically, and substance use disorder in general. Just in 2018, they had over 1,300 deaths. They had over 9,000 overdoses. They had over 400 children that were born to substance abuse patients, substance abuse disorder patients. So what did Blue Cross or Blue Shield in Arizona do? Well, it supported the local resources, the local community, the Center for Hope, the Center Point for Hope, and the Crisis Response Network there started an mobile MAT bus unit, a bus that it's a big travel size bus that you would go on a cross-country trip. They outfitted it to be essentially a mobile clinic. And and their goal in 1 year, starting in the middle of 2018, so it's still going on, is to travel to 72 locations within the state. And needless to say, they were overwhelmed with the engagement with the number of people that came to that mobile clinic and are continuing to come to that mobile clinic. They announce prior to arriving in a city, they alert the first responders, the police and the fire, that they're coming, and they also have a press release. And so they have gotten just an overwhelming amount of people in need, frankly. and they first, and on that bus, they have providers, they have navigators, and some of what they do first is really look at the social determinants and things of that nature, the things that actually prevent you from acting on and in your own best interest for care. So they first address food insecurity, resources such as safe and adequate housing, and then direct those folks to resources where they can make sure that they receive these care, social determinant care actions. Then they move to how best to get them the treatment that they needed, whether it was for substance use or for other drug abuse or alcohol abuse. And the reception, I just can say, is very overwhelming. That's just one example of one plan. There are many plans that have done similar things based on the intimacy of their knowledge of what goes on in their markets, their patient population, their communities, and the socioeconomic circumstances. And so with that, I'm gonna take a pause, and that was my presentation. Thank you.
Well, thank you all for your overviews. I'd like to remind everyone that this is being recorded and the slides will be available, and also that there's a chat box on your screen. And if you could have any questions, if you could just add those into the chat box, we are absolutely monitoring those and we'll be addressing them. And so I would actually like to start off with a couple of questions we've had so far about telemedicine. And I know, folks have been talking about this today. One of the things that I've seen in here are questions about quality issues with the utilization of beyond what would be typically called telemedicine, just virtual visits. And a number of payers are including CMS, are paying for telephonic only visits, which of course would not have met telemedicine requirements in the past. So questions about sort of the quality of telemedicine, and then questions about those payment issues around telemedicine, because there are some areas in which we've seen some health plans are not covering. Some are covering, but at much less than in-person rates. Some are covering at in-person rates. And so I'm wondering if you could address, each of you, what you are seeing and hearing around the utilization of telemedicine in terms of what those challenges are around quality of care, and also around the payment structures. And then particularly, Dr. Nelson, for you, what your feeling is, if you have some, about the totality of your plans doing coverage for, that is consistent with CMS coverage for telephonic. So I'll just start, I'll leave it there, and interested in hearing your responses.
Well, I guess I'll go first.
Go ahead.
So when I came to the association, I was, like an advocate of telehealth and virtual care. I could see it, and it's not, I don't think it was that new of an insight that we were moving in that direction. And I think the catalyst obviously has been our shelter in place, and the fact that we need to both protect the patient and the provider during this pandemic. And so telehealth has really catapulted into everyone's consciousness. And I think that those that were formerly uncomfortable with telehealth have either gotten comfortable or will be getting comfortable with the delivery and the recipient of being cared for, at least on the in the areas where it's scoped appropriately. That said, the Blue Cross Blue Shield Association did put out a series of priorities where we left it to our plans that are independently functioning, but that we would adhere to all guidelines that were related to telehealth based on market conditions and based on CDC guidance. Several plans instituted a pay parity for providers, so that providers would get reimbursed the same for a telehealth visit as they would for an in-person visit. We also relaxed prior authorization for telehealth, where formerly what some plans have relaxed prior authorization in some markets for telehealth visits where formerly there might have been prior auth inconsistency for in-person versus telehealth. And we are always in close contact with CMS and other regulators to make sure that we are keeping pace with the current guidelines. And so we are very pro, getting the care that our members need, which includes at this time telehealth visits. Many have already extended it to be indefinite, so it most likely will not end when hopefully the pandemic ends. And so we are definitely here to remove the friction for our members to receive care in any modality that they need to.
So
Okay.
what I can tell you we have seen in our system is that the platforms that are acceptable in terms of the security of the connection often are unwieldy, and that has proven to be challenging. And so it has taken quite some time to work out bugs with our information technology people to figure out how to get past poor connections, what to do in situations where our patients, for instance, may not have access to smartphones. Some of them don't. And in rural Pennsylvania, there are areas where cell phone coverage is poor, and that simply isn't something that can be done. So it is all quite a challenge and frustrating. And I think over time, all of the folks that practice with us have come to say, I really prefer to see people on video. There are pieces of information that we get just being able to see the patient's physical well-being. But sometimes the connections are simply impossible and will be completed simply with audio.
Right, I would mirror that experience that we've similarly had many patients who have not had access to the video component. So we've had to pivot and be flexible around the use of the telephone only, which obviously leaves a fair amount of, it just can be more difficult to engage patients with voice only. That being said, I've noticed that our patients have been very flexible with us during this period of time as we have tried to think about how we continue to have access available. And so many of them have been quite understanding and so incredibly grateful when we're able to continue this care even by the phone. I think there are ongoing questions about how long can we continue to provide some of this care only over the phone. And, I think that we're going to have to think about different ways of monitoring our patients. So ways that I've done that with some of our patients that I've been concerned about is obviously with their permission, speaking with their loved ones about how they're doing, to get a quote more objective reflection, if you will. So there are other ways that you can provide that support to your patients, even if you're not seeing them face to face. I would, though, end by saying that many of our patients have really not done well with the telephone or video platform and have really wanted only to be seen in person. So we are continuing to be available for in-person visits, and that's been incredibly important for some of our patients.
Thank you. So we've had a number of questions kind of pop up around here on the chat, and thank you all for starting to use it. And I'll try to get to as many as I can. There are questions about alterations in practice patterns. utilizing telemedicine and et cetera. And so I'll take an opportunity to just make folks aware of a couple of resources that are available. The issue around how difficult it can be to access telehealth services was, I think, well discussed on the first National Academy of Medicine, American Society of Addiction Medicine webinar about 2 weeks ago, and you can find those documents on the both of the websites. The issue around the changing practice patterns, particularly around drug screens, drug tests, as well as drug screens. And as I mentioned, there is clinical guidance up on the ASAM website about that. But very, very interesting questions around here about drug testing as a preparation for medication treatment for opioid use disorder is a challenge. And then a statement here that I think is particularly interesting to discuss, which is that some providers want to do cheek swabs, take swabs and use saliva testing, which is discussed in the ASAM document. But the State Department of Medicaid has weighed in to say it cannot be done by telehealth. So there are two potential issues with your State Department of Medicaid. The first is the state may have regulatory requirements that say thou must do X number of drug tests, which again would be absolutely inconsistent with the federal guidance and requirements. And this is why it is so important to get people on the ground in the states to coordinate and collaborate to make sure that the states move forward in some of these manners. But the second issue is simply around, you could do it, but Medicaid won't pay for those drug tests. So I guess maybe to that issue, if any of you want to talk about those kinds of issues, some of the changes that we've had to make in practice patterns, and drug testing is a fine example of that, but the changes that have to be made in practice patterns, and then how payment can be really putting up a barrier to those, and any examples of those you have.
Sure. So as prior to COVID, our system had been ramping up to use more telemedicine and had made arrangements to do saliva testing, observed by video, as our way of screening our patients. And saliva testing it's not bad, but it isn't quite as sophisticated and nuanced as urine testing is in this field. Nonetheless, it has place. We ended up realizing that many of the insurers that we deal with in our area would not pay for saliva testing, which has had, up till this time, limited how much telemedicine we could do. Now, we still haven't pushed quite as hard as we will to get more payment for that saliva testing, but that's absolutely not something we want to pass on to our patients. But we're going to start working with those insurers around getting that managed. And so, again, talk to me in 6 months. I may have a really different story to tell you at the point that we can sit down and reflect on what we've seen. And we also, our system has adopted a scheme by which patients that we feel uneasy about in terms of their progress, we have been bringing back in person and collecting urine screens on. And, often for good reason. There's use other than just opiates and things that we need to be cautious of, and we want to help address that with our patients. So while we have made less use of drug screens than we did 6 months ago, we are being thoughtful about continuing to use both the urine and saliva toxicologies. And we may, like I said, we may learn a great deal about this as we have time to collect information about how this is all working. But right now, this has been primarily an issue of we'll do the best we can, and in many ways, keeping patients engaged has been what we've been most put the most emphasis on.
Anyone else?
I would just say that, you know, in our state, we had a lot of, we didn't have much clarity on some of the payment structures for the televideo or telephonic appointments for quite a while. So some of the shifting and challenges that we had were kind of working through those different payment structures as we were still trying to provide care. And I'm sure that was probably an issue for others in other parts of the country as well. So I think many of us are just trying to catch up with this, where we are and how do we appropriately reimburse for the time that we're still giving to our patients to provide care. So it's definitely something that as this pandemic goes on, that we're going to have to work collaboratively to sort out, because we still need to be able to provide treatment to our patients.
Dr. Nelson, anything to add to that?
Well, I'll just say that, you know, I am an anesthesiologist and practiced pain medicine for a number of years before coming to industry. So by extension, I had to also deal with patients that also had co-addictions and have to get urine drug screens and abide by both the state regulations and other regulations to manage my patients. And essentially, just to say, I completely understand this this sphere of difficulty. I'd just like everyone to appreciate too that, you know, health plans like other companies had to, you know, rush out of the offices to home, and we had to react very quickly to this changing environment that keeps changing based on the virus and the government. And we are working collaboratively through our plans to make sure that we are, you know, again, removing those frictions. We don't want to see anyone, you know, like receive substandard care or not timely care. And so we're working overtime to make sure that everyone gets what they deserve.
Right, and I would call out that the example that we used to discuss this issue about payment and changing of practice patterns was around drug testing. But drug testing is a significant source of fraud, waste, and abuse within the healthcare system. And it also leads us to that issue about quality and how we can ensure appropriate quality of care while we're changing where and how care is occurring. One of the questions that came up here was around, you know, when are we going to see and know how the quality and how outcomes, how it's really worked for patients utilizing some of these less frequent touches, if you will, with some of the relaxation of the federal and state guidance and requirements and et cetera. And, you know, the claims data are going to be interesting, but really there's nothing in the claims data that lets you know if a person's been a telephonic only or an audio video only, or, you know, how that's really been put together. And that is something that at the collaborative, the National Academy of Medicine's Opioid Collaborative, is being discussed as part of the research data and metrics group. How can we gather some of these data to allow us to move forward into best practices using what we're learning right now? And it's very difficult to find those data and to even conceptualize how we will do it. But it's an excellent question, and a number of people are giving good energy to considering that right now. And when we're talking a little bit about here on isolation and patients' feelings of isolation, and again, this was a topic of the last National Academy ASAM webinar, but maybe if we could hear from you in the field, how you've seen some of the efforts with all of these changes to decrease isolation in the patient population, but also, and I know Dr. Jarvis, you've been working on this too, the providers, the clinicians' feeling of isolation, which has been pretty profound in a number of different settings. So I'll open it up to you to give us your experience and expertise on some of those issues.
Well, one of the things that's been really wonderful, and I'm hoping that Dr. Weimer can comment on this too, is that as we have engaged with patients through video and virtual visits, one of the things we've heard over and over and over is, we are so grateful that you are still there to take care of us, over and over again, and how much they appreciate the fact that we're calling them, we want to check on them. And we've been quite busy and had a lot of extra touches especially with people we were most worried about. And that has been very well received. I will say that from the other end of things, the switch to telemedicine work, especially telemedicine work from home, has not been entirely simple just for the providers who now find themselves, it's a really different work pace, and it is isolating. And so I'm hearing people say, I want to make sure that I'm back in the office at least a couple of days a week because I miss the team that I work with. I miss a different pace and way of seeing patients. And that has had an effect. Dr. Weimer, what are you seeing and hearing there?
Well, I have 2 young kids at home, so I don't, not very isolated, I will say. That being said, some things that we have done to remain connected as a team is we have actually increased our number of team huddles per day. So our team actually meets, initially during the pandemic, we were meeting 3 times a day via Zoom to stay all connected, because a lot of the work that we do is team-based. So it's really important that we maintained that communication that which previously was so easy, but now was so much harder. So that's something that we had done. And that, I think, helped people feel more connected. For our patients, we have, like I said, maintained some in-person visits, and for some that's been really key and important for them. For others, we have really encouraged them to maintain social connection through many of the different virtual resources that are available now. All of the support meetings are occurring many via Zoom or other platforms. So we've been making sure they have a list of those different virtual supports. We have our peers and counselors reaching out to them as well to maintain those touches of support. So it's not the same by any stretch, but I do think this new, some of the new ways that we're trying to continue to remain engaged with our patients and has, under the circumstances, been worthwhile and helpful.
Great, and I think this was probably then for you, Dr. Nelson, in terms of the connecting patients via digital apps, via, there's a large group of companies that have been marketing a variety of different tools to keep patients with addictive disease and other behavioral health conditions connected and less isolated. And I'm wondering if you could maybe speak to any that you know, any of the Blue Cross plans have worked with, or if any, not particular products, of course, but just sort of in general, those sort of digital connection issues.
Yes, we are always on the lookout and exploring with health technology companies that are innovating around care, whether it's point solutions or systematizing some processes that are, let's say, fragmented or uneven. And so I know there are, I don't want to step into, you know, unintentionally advocating for a few of the technology platforms, but I do know especially many of our plans in the Western United States and like even some elsewhere have definitely been engaged in technology platforms that actually connect our members to resources, particularly around behavioral health. We are seeing an uptick in telehealth and virtual care related to behavioral health. In some cases, 200% and 300%. I think one plan even said 1,000%. And I think that it is true that behavioral health is based, you know, because of this social isolation that should be, I like to say, physically distanced, not socially distanced, but this de facto social isolation that's happening is increasing members that feel like they are having a difficult time adjusting from a behavioral health standpoint. There was a Lancet article or a peer-reviewed systematic review of studies done on pandemics like Ebola, SARS, H1N1, and it was done. And this systematic review looked at studies that were done on social isolation and behavioral health, because a lot of these communities, especially in Europe, too, had the option to isolate or not. And it was shown, even in a systematic review of several studies, that there was almost a threefold difference in behavioral health issues related to those that had to shelter in place or isolate versus those that did not. And so we are anticipating that increase in behavioral health issues and needing care to extend out past, hopefully, when this is starting to subside.
Okay. I want to get to a couple of the other comments and questions that have come up. There's just a number of questions about drug testing, and I'll just throw out there, I've done a number of cases for the United States Department of Justice, criminal fraud cases around drug testing, where specimens are being sent for $1, $2, $3, $4, $8,000 per drug test specimen. So it really is an interesting area that folks need to be careful about in all ways. Another thing that I'm seeing quite a bit of in this discussion here is around SBIRT and alcohol. And SBIRT, of course, is a technique that's primarily utilized to help people who are at risk for unhealthy drinking and for nicotine use to have an intervention by their clinician to keep them from really moving into a pattern of addictive disease. Is primarily around that. And the referral to treatment once actual addictive disease is in place is really what we're kind of talking about here, is how that access to treatment is occurring, and et cetera. It's not really around opioid use disorders or cocaine. You know, people know when they are having those issues. They don't often know that they're having risky drinking. But I think Dr. Jarvis mentioned this before, and there was a question in here that's sort of concerning about, you know, how much can you cut down before going into withdrawal? And withdrawal from alcohol, benzodiazepines, barbiturates, you know, the 3 Bs, benzo, bars, and booze, those can be life-threatening withdrawals. That's not like opiate withdrawal. That's not like cocaine withdrawal, right? That's not like pretty much any other kind of withdrawal you're talking about. Those are very dangerous withdrawals. And I think, as Dr. Jarvis, you were speaking a bit about the kind of alcohol consumption that you're seeing. I'm just hoping maybe you and Dr. Weimer could talk about SBIRT around alcohol and nicotine use, but particularly here also around the issues about accessing treatment for physiological alcohol dependence and alcohol addiction?
Well, golly, Ned, as you said, SBIRT is a technique that is used to help begin engagement in the healthcare process around a substance use disorder. So it's only applied at a time when a patient is not seeking help for that, but perhaps the professionals or those around them recognize that there is potentially a problem. That is a little bit different from the person who might arrive in an emergency department saying, I just had a seizure, I have been drinking more than usual, or they call their primary care doctor perhaps, or call the a drug and alcohol rehab asking for admission. That's a different part of the process. And one of the things about treating alcohol withdrawal or benzodiazepine withdrawal is that there are a lot of ways that it can be done and that it can be done safely. There is no one size fits all. There's no one dose fits all. And it depends. And so as ASAM considered the recently released guideline on the management of alcohol withdrawal, there was some desire to be able to create protocols that would say, you know, give a patient this much Librium every 3 hours and that will take care of things. But the expert panel, though they wanted to be helpful and they know the desire to make things easy for the emergency physicians and the hospitalists who don't know a lot about this, kept saying, it depends so much on the patient's other physiological parameters. It depends so much on how their body reacts to the alcohol that there's no really safe way to say, just drink 3 beers 4 times a day and you're going to be fine. That's simply not going to work. It really needs to be directed by a professional who has the capability of monitoring and watching as that person goes through withdrawal. Now, that doesn't mean it has to be accomplished on an inpatient unit, but it does need to be done with somebody who is well-versed in managing these kinds of syndromes. Dr. Weimer, I see you nodding.
I agree with a lot of what you said. And I would say, you know, I think SBIRT provides a nice framework for screening. But as you said, many of the patients who are coming in with, say, overdose have kind of passed that point. So I would use it as maybe a starting point to start the conversation if you're not sure how to start the conversation. But then from there, it gets, particularly for those who are experiencing alcohol withdrawal, it's important that we're safely evaluating and determining whether this patient needs to be treated in the hospital setting, acute setting, subacute setting, or if they could potentially be treated at home. And then I think it's always important, particularly for those with alcohol use disorder, to offer evidence-based treatments, medications, and other behavioral treatments for ongoing care. So I think I'll stop there because I think we're almost out of time.
Sure. You know, I would add one thing to that, which is, I think in the first one of the series, we had Dr. Brian Hurley speaking, and he is treating something like 4,500 patients in LA County in RVs who are homeless. And he has actually on the ASAM site a the document on how he's doing sort of a population-based approach to withdrawal management, which is really different than the normal, approach. And that, I think, is an excellent example of the pivoting we're doing in terms of individual clinicians and in terms of entire healthcare systems to have to change what would be our normal best practice, given all the resources that we would normally have, into what's possible to take care of the totality of the population under these current conditions. So we are pretty much out of time, but I'd like to give you each, 30 seconds to say if you had a take-home, kind of statement around, today's topic, the challenges of providing addiction treatment care throughout the continuum of care during COVID. What would those, 30 seconds to give those statements?
Though there's a temptation to make decisions quickly, one big takeaway that I've seen from our system is that you really do have to put the time in to make decisions thoughtfully.
I would say that the hospital doors are still open and we are still available, and it's still a great opportunity for us to treat our most vulnerable patients who are coming in, and it's important that we're providing evidence-based treatments.
And I guess I will end with, we at Blue Cross Blue Shield are definitely thinking about all of our members, and not just our members, but the population at large, and making sure that we support all of them with all of our resources that we can to facilitate the equitable, evidence-based care that they need.
Great. Liz, do you have any final words here today after I thank our panelists for a terrific session and remind people that this and the first sessions are going to be available on both websites, and there is a third coming up?
That's right. Yes, no, thank you all. This has been a really informative and terrific session with great discussion. And I just want to extend my personal thanks to ASAM, as well as all of you who spoke today, and to all the webinar attendees for participating. As Kelly mentioned, the webinar has been recorded, and you can find the webinar recording, speaker slides, as well as information on continuing education credits at nam.edu/treatment webinars. And yes, we do have a third webinar coming up on Tuesday, June 2nd, and that webinar is going to focus on coordination across the social safety net to avert crisis among patients with addiction, and we're going to focus in particular on the homeless and criminal justice population, so that should be a really interesting discussion. So yeah, just my final thanks for all of your participation, and I hope everyone stays safe and well and enjoys their long weekends.
Thank you all.
Thank you.